because I unfortunately have had a lot of experience with this. I think I'll start by sharing my screen. Okay, and I think when this issue first came up, people were actually talking about DISH, and so I thought a catchy title for this might be dealing with DISH, but really it's a discussion of the issues surrounding using oral retinoids to treat ichthyosis. Now, there are a whole lot of things that we could talk about regarding oral retinoids, but I think for for purposes of brevity and for getting right into the things that were concerning to that chat group, we'll just restrict ourselves to talking about the issues that people who take retinoids might be having with their bones. So just to get started, I'll remind you that vitamin A is a vitamin. It's in everybody's diet. It's rare for people people almost anywhere now, especially in Western Hemisphere, to have vitamin A deficiency. But it's possible if you take vitamin A by mouth to get too much vitamin A, and that's where you get into problems. Vitamin A is made in the body after you eat beta carotene. That's this thing at the bottom here. But the body, if you're eating beta carotene, has a very careful way of regulating how much of the beta carotene is actually turned into vitamin A. So it's very hard to give yourself hypervitaminosis A just by eating food. But it's certainly possible to do it by exogenous sources of the vitamin itself. Now, can you see the top of this slide, or is it being blocked by my taskbar?
We can see the top of the slide.
Okay, I can see it. So there was recently a consensus conference dealing with vitamin A and potential bone toxicity, and this was published in Pediatric Dermatology a couple of years ago. Vitamin A is used therapeutically in a number of circumstances. It's probably got its first use in dermatology, but now it's used significantly in oncology to treat certain kinds of cancers. And a lot of the information that's now in the literature about vitamin A toxicity in bones comes from that literature, although the literature started in dermatology and in patients who had ichthyosis. And we know that vitamin A is really necessary for normal bone growth, but we also have known for a long time that if you give too much vitamin A to animals, you can have other problems like fractures and ligamentous calcifications. If you look at the human literature for eating too much or taking too much therapeutic vitamin A, the main thing that stands out are the ligamentous calcifications. And this happens with all kinds of vitamin A in the diet, and the problem then becomes DISH. And we'll talk more about that in a minute. Some of these other problems are exceedingly rare. They happen often in the oncology literature because the people who are being treated with retinoids in oncology get much higher doses than people who have ichthyosis. There was a few cases of fused epiphyses, which means that bones stop growing normally in children. This happened in a couple of patients with ichthyosis early on, but the amount of retinoid that's now given to treat ichthyosis has never been associated with a fused epiphysis. So these problems are extremely rare. The one that we're really interested in today are these ligamentous calcifications. And when we're talking about that, this is an X-ray of somebody's heel, and there's a tendon that goes into the back of the heel here, the Achilles tendon. And normally you don't see this little calcification. There shouldn't be calcification in this ligament. It should be invisible on this X-ray. One of the other problems was this loss of the growth plate in a growing bone. This is what a fused epiphysis would look like. This is a normal epiphysis here. It's been fused here. And then in the spine, you get these calcifications in the ligament that is in front of the vertebral bodies. So if this is the front of the patient is over here and the back is over here, these are the vertebral bodies in the lumbar area. And normally you have this ligament that goes in front of these vertebral bodies, and you don't see anything there because there shouldn't be any calcium there. But if you start getting calcifications, you start seeing these kinds of little white spots on an X-ray. And this is the sort of thing that is very common when people have too much vitamin A, but it's also extremely common. And that's what we're going to talk about now. So diffuse idiopathic skeletal hyperostosis, DISH, is really, it's a fancy way of saying there's calcium in places where it shouldn't be. And that's what I've just been showing you. There's calcium in ligaments where it really shouldn't be. And there's a very clear definition for DISH, which is calcification of the anterior spinal ligament that spans 4 or more vertebrae without the loss of the disc height, which means the spaces between those vertebral bodies are not compressed. Now, what's really important for everybody to understand now is that in the general population, 6 to 12% of people will have DISH. And somebody my age, probably people my age, are likely to have DISH at the rate of 28%. 28% of men and women who get to be my age will have DISH. It's a very, very common problem. You can see it usually starts later in life. At 50 years of age, 25% of males will have it, 15% of females will have it. But by 80 years old, 28 to 29% of people will have DISH. Now, the difference is for people with ichthyosis is that it's very clear that with any kind of exogenous retinoid, the DISH occurs at an earlier age, and it often is more extensive than it would be in the normal population. There's no question that this happens. This is something that John DiGiovanna wrote about 40 years ago. I saw it as well in some of my patients. And it's something that we've known about for a long, long time. And this is what it would look like on an X-ray. So this is an X-ray of somebody's neck. And you can see here the vertebral bodies. The space between the vertebral bodies is maintained, but there's this calcification, what's called flowing calcification in this ligament that's in front of the vertebral bodies. This is somebody's chest. Again, here are the vertebral bodies and the disc spaces between them, and the calcification is just flowing right along here in this ligament. So this is what DISH looks like by X-ray. It's very easy to make this diagnosis. It's easy to make the diagnosis, but it's not so distinguish it from other problems. And the problems that you need to be, the one problem that you need to distinguish it from particularly is ankylosing spondylitis. And the reason for that is that ankylosing spondylitis occurs in younger people as opposed to the DISH that occurs in people who aren't retinoids. And so if you start DISH, if you start a retinoid because of your ichthyosis at an early age and you start having some symptoms, you need to be evaluated. And the reason you need to be evaluated is that down here, DISH, compared to ankylosing spondylitis, tends to be relatively mild or even painless. The symptoms from DISH are mild in comparison to extensive changes on X-ray, and DISH is often discovered, as John and I found back in the days when retinoids were first used for ichthyosis. We were taking X-rays because we were concerned that there might be a problem, not because our patients were complaining that they were having pain. So these are two important things: to distinguish DISH from ankylosing spondylitis, and to understand that for most people, at least in the general population who gets DISH, it's an asymptomatic problem. So if you have musculoskeletal problems, what should you do? Well, clearly you should go to a rheumatologist. to make sure that you have dish and not something else like ankylosing spondylitis or some other problem that might be affecting your the calcification in your joints or your ligaments. And then I think it's reasonable to work with a professional to improve flexibility. Now, these two things, there's not a lot of, I mean, these make common sense, but there's a big literature on dish, but there's very little information on treatments that are effective for dish. I want to just mention two things, not to worry anybody, but there are a number of things that have been tried. So the first thing to remember is exercise. Unfortunately, this was a good study, but it didn't reach statistical significance. And yet the people who wrote it said an exercise program designed for dish and tested led to small improvements in physical measurements, which achieved significance only for the lumbosacral flexion. Well, there were improvements, it appeared, and I think that there's absolutely nothing wrong with doing some physical therapy. So just going back to this, I think it is important if you're having any, or you think you're having any problems with dish or other calcifications, to see a rheumatologist to make sure you don't have something else, and then to work with somebody to improve your flexibility. Now, there have been some people who have had such severe dish in their neck that they have trouble swallowing. And this is the only real symptom that I've been able to find in the literature for which anybody was terribly concerned. And there have been a number of surgical approaches that sort of scrape the calcium off of that ligament to help swallowing, and there's been moderate success with that, but it hasn't been overwhelmingly successful. Okay, so that's I think a reasonable place for us to start. Now you can all turn on your videos, and we can I'll take questions if there are people who want to make comments about their experience with musculoskeletal issues or have observations that I haven't dealt with. Now's the time to do it.
And make sure you unmute yourself so we can hear you, because you were all muted.
Have we gotten rid of my screen?
Your screen is still up there. Do you want to stop sharing?
Yes. Oh, there we go. Stop sharing. Great.
There you go.
I think I typed a question. I don't know if you have it listed in front of you, but I've had my hips replaced. I took Accutane 32 years ago for 10 years, from 16 to age 26, but both my hips have been replaced, and now my neck and spine are calcified, which really aren't that bad, but now my shoulders, forearms, and hands are really hurting, losing strength, grip strength, hands falling asleep. Can that, or is that related, do you think? Shoulders pop, creak, and snap, and
yeah. So I can't make that evaluation. I'm not a rheumatologist. I haven't seen your X-rays. You obviously had some things that may or may not be related to taking the Accutane. I think one thing that I may have skipped over early on the first slide is that it's pretty clear that the changes that occur from taking oral retinoids, the changes that occur in the musculoskeletal system, are related to dose and to duration. So the longer you take it and the higher the dose, the more likely you are to have issues. So I think, Keith, have you seen a rheumatologist to evaluate these issues?
I did many years ago, but I mean, all the X-rays they've done and everything, they never found anything like even arthritis, except for like the calcification on my neck and spine. But that was 32 years ago. I guess I'm not sure what the next thing to do would be. I mean, if it doesn't show up on an X-ray, I don't know.
You know, there are now there are a lot of causes for arthritis, a lot of causes for people to have arthritis in their hips, for example, that would be quite independent of taking a retinoid. So if you're having what we call polyarticular arthritis, it's something that really should be evaluated by a rheumatologist even before you go to see an orthopedist for a particular joint. You could have rheumatoid arthritis, you could have RC arthritis, depending on what kind of work and athletic activity you've done in the past. I think a good evaluation is worthwhile for anybody who is having symptoms, because like I said early on, for most people who have calcifications in their anterior longitudinal ligament, who have DISH, it's asymptomatic.
Okay.
Dr. Milstone, I don't mean to cut off if the other question was still going on.
No, I think
my question is, what would you mention to your primary care provider to get a referral to see a rheumatologist? If what you're saying is sometimes the symptoms are mild or maybe non-specific, or it's even difficult to detect by X-ray or radiologic images.
So I've treated quite a few people over the years with oral retinoids, and early on we were taking X-rays on a regular basis. Now we only take X-rays irregularly to see if there's progression. But what I need to tell you is that I don't think any of my patients ever complained of pain in their spine. I have two patients who had extremely severe DISH, and they complained of stiffness, but they did not complain of pain. And so that's a small sample. There may be people out there who have DISH and who do have pain, but if you have pain, that's another good reason for seeing a rheumatologist. If you don't have pain, the question is, why do you want this info? Why do you want to have an X-ray? Why do you want to go to a rheumatologist? Chances are if you're taking a retinoid, they're going to do an X-ray and they're likely to find calcification somewhere. But if they're not symptomatic, you're probably not going to do anything about it. I will tell you two other things. One is that I have some patients who I've followed for 40 years who are athletic, and they have no calcifications in their anterior longitudinal ligament. They have no evidence of DISH. So there's a genetic factor here as something to do with the retinoids.
I had several questions, if it's okay to chime in now. My 12-year-old son who has lamellar just started taking oral retinoids. Right. And so I wrote down a couple questions. I'll read the questions, and then if you can kind of answer them. How long does it take to develop DISH? Is it after 1 month of taking this, or 30 years? And then you spoke about dose. So specifically, he's on 10 milligrams, which I know is a very low dose. Does that decrease the likelihood of him developing this? And then of the ichthyosis patients that you've treated with this, how many, are we talking 50% develop it? Are we talking 100%? And then also, will it impact his growth, like his physical height? And then also, if he stops the medicine, even if DISH has developed, can it be reversed? And then my last questions are, if symptoms are mild or none, does it really matter? So let's say you have it, but you don't have symptoms, then it's just like, well, you're fine.
I'm going to have to go back and find your questions because I'm not going to remember all of those questions.
I'm sorry. Okay, so the first one was, how long does it take to develop?
Let me just start with the ones that I think I remember hearing. First of all, 10 milligrams is very low. It's not likely to cause a problem, but 40 years ago, John DiGiovanna found that some people who were taking isotretinoin for their acne, which is usually a 6-month course of maybe 40 milligrams to 60 milligrams, some of those people did get calcifications. Again, they were asymptomatic. We do not have data on how many people who take retinoids get DISH. it's probably, well, I mean, if normal people get dish, if 28% of people my age have dish, it's probably a fairly large number, probably more than the control group who haven't had an oral retinoid. 10 milligrams is not going to inhibit somebody's growth. Ask
So
another question.
can dish cause any sort of stunting of growth?
No, not the dish. Dish does not have anything to do with growth. The problem with the growth plate is obviously something that ends once somebody is fully mature, but that has nothing to do with the calcifications that are occurring in the ligament. Vitamin A is quite essential for bone growth, and so you need some vitamin A. But 10 milligrams is not going to be harmful to growth.
Okay, and then my final question was, if if you develop dish but you stop the medicine, will it improve or go back to normal or anything like that?
Excellent question, and nobody has really done that test. Based on what we know in adults who have dish not related to retinoids, it does not go away. Once it's there, it stays there. It's progressive, and it will get more and more calcification.
Dr. Milstone, I was wondering whether it can cause any stenosis or scoliosis.
We do not know. Probably not. There's a very strong genetic factor, excuse me, for scoliosis and kyphosis. And stenosis is a completely different problem, although it is caused by calcifications. But again, that's something that really ought to be evaluated. And again, it's dose dependent, and it's not clear that if you were to stop the retinoid, that would change. But I would guess that those problems are not related to a retinoid.
Okay, thank you.
There are some questions in the chat, Len. Let me just make sure. Let's see. We talked about the primary care. How long does it take for dish to become symptomatic? You kind of answered that with Lauren. It doesn't necessarily become symptomatic, right?
It does not. I mean, in my experience, it is usually not symptomatic, and that certainly is the case for people who have dish unrelated to taking a retinoid. The 28% of people my age with dish generally are stiff, but they don't hurt.
Okay. Let's see. And what is considered long-term use? A lifetime. I mean, for most people with ichthyosis, they start taking the treatment when they are either children or teenagers, and they keep taking it. I will tell you that the two people who I've treated with very severe dish and very severe stiffness, I had long conversations with them about stopping the retinoid. Neither of them were willing to do that. They felt that the benefit to their skin outweighed the stiffness that they were having. The next question was, the guidelines released a few years ago suggest that retinoids at low doses are relatively safe. What are your thoughts on this with regards to the risk of dish? You kind of talked about that.
I think that's true. I think the risk is very low for low dose retinoids. But like I said, even people who had retinoids for 6 months for their acne did get some calcifications. None of them really developed dish, where you had 4 vertebrae adjacent with the calcification, but they could identify some calcification in that ligament in a very short period of time in a small number of people.
Okay.
Besides blood work and x-rays, what are some other ways to monitor early potential negative effects of DISH or other severe effects of using oral retinoids?
Okay, and I presume this question from Samuel is related just to other problems being other musculoskeletal problems. I mean, obviously, I don't want to discount the issue with pregnancy. I don't want to discount the side effects that some people have from chapped lips, but I think we're just going to focus on the musculoskeletal issues today. And there is not a uniform way of following this. In that that paper that I mentioned, it was in Pediatric Dermatology a couple of years ago. That was a consensus conference in which we all tried to decide what was a reasonable way to monitor people for musculoskeletal side effects. I think the first thing is that if you have symptoms, you need to be evaluated by x-rays and a rheumatologist. If you don't have symptoms, my usual way is when I start somebody on a retinoid and it appears that they feel they are getting a significant benefit from it and that they might want to stay on it for more than 6 months, I will get a baseline series of x-rays of their spine just to find out what was there at baseline. You know, if you're a teenager, there's probably going to be nothing there. But if you start the retinoid when you're 40, there already may be some calcification. So it's worthwhile to know what's there when you start the retinoid. After that, I wait 5 years and do another series of x-rays just to see if there has been any additional change in that calcification of that spinal ligament. And after that, that's where we don't know. Some people would do it every 5 years. Some people would wait for symptoms to occur. We just don't have a standard way of approaching this. Okay, related but separate.
You mentioned it being progressive. I mean, again, the general population, 80 plus, you said 28%. Now, as far as being progressive, if it were to start when you're 30, because you've been taking retinoids, and it gets to the worst that what are the worst, most severe symptoms? Like when we talk stiffness, are we speaking like inability to walk, or are we just talking, you wake up and you're a little tight?
So the two people I mentioned were in the original isotretinoin trial in the late 1970s. And they took an oral retinoid for their entire life. And stiffness was the only complaint either one of them ever had. And it actually got to the point where they didn't want to have more x-rays and they didn't want to go back to the rheumatologist anymore. They were doing their stretches and they had decided that, this is what they were going to live with. But, that's a 50-year experience, almost a 50-year experience.
Okay, so you're saying I have lots of pain, shoulders, knees, back, everything. So you're saying I should see a rheumatologist before I see an orthopedic doctor?
I would. I mean, there are common diseases like rheumatoid arthritis. There are other common causes for polyarticular arthritis, more than one joint. And like I said, most of the problems that occur from retinoids are asymptomatic. Now, the one place where that might not be true are those heel spurs. I showed you that heel because people are constantly walking, and heel spurs, whatever their cause, do become symptomatic. But and I think that's because of the pressure as well as the calcification.
Thank you.
Dr. Milstone, what about those of us who haven't been on retinoids for years and years and years? but we still have these symptoms. Should we pursue a rheumatologist also before an orthopedic?
Yeah, Hunter, I think you probably know the answer to this. I think there have been a couple of recent studies. People have gotten interested in the aches and pains that ichthyosis patients have in their joints. And it appears that arthritis, pain in the joints, is more common in ichthyosis than we would expect. But we do not have a good explanation for that, although there are theories that suggest that anything that causes chronic inflammation can give you problems in your joints, but it's complicated. So again, I think that if you're having pain in your joints, it's worth going to see a rheumatologist. Now, I'm not sure what they're going to offer, but at least they can tell you do not have, you do not have rheumatoid arthritis, you do not have lupus erythematosus, you don't have X, Y, and Z. This is maybe related to your ichthyosis, but it's not something that we put a name on. And it's not something that we have a new therapy for. There are a lot of new therapies out there for arthritis that work quite well. So that's clearly one of the reasons to see a rheumatologist if you're having joint pain. Yes, Helen, you're right. If you have an impaired skin barrier, your skin becomes inflamed. That's something that we've known for a long time. What we are only now beginning to wonder about is whether that inflammation in the skin can have systemic problems, whether it can cause problems elsewhere other than red skin.
Knowing what you know, if you had a 12-year-old, would you put them long-term on a oral retinoid? Or really anyone for that matter?
Yes, I would not hesitate to do that if the ichthyosis were severe enough to treat. Now, remember, there are many people with ichthyosis whose problems are much less than probably many people on the call today. I mean, I do have ichthyosis patients who do not want retinoid treatment and who do quite well. Certainly, people with ichthyosis vulgaris, people with X-linked ichthyosis, generally do not go on oral retinoids because their scaliness and their redness just don't seem to warrant that kind of treatment. But if I had a child with severe ichthyosis, I would definitely use it.
I have a question, Dr. Milstone. I'm Lauren's mom.
Oh,
and
okay.
I'm a grandma. I met you many years ago at Yale when we brought Calvin years ago. But anyhow, my questions are, so my assumption is that incrementally, if the dose goes up, you're more likely to develop DISH. Am I correct in saying that?
Well,
we keep talking about the gal who spoke about 10 milligrams. You said, oh, at 10 milligrams, you probably won't see it. So yes, that made me wonder about the dosage.
Yeah, so we actually don't have good data on that. We have good data on some of the other things. We have good data on fused epiphyses. We have pretty good data on, at least in animals, on whether you can get osteopenia, whether you can actually lose calcium in your bones. It's clearly in animals that happens, and that is dose related. We actually don't have very much dose information about DISH. And one of the reasons for that is that animals don't get DISH. Their cats will get DISH, and there's one study done in cats, but most other experimental animals don't get DISH. You can't give them DISH.
So the dosage might not be the factor or the reason.
Exactly. I mean, clearly, some people remember. I have this one patient who has no sign of the dish, and he's been on the retinoid for 45 years. So there's genetics is still important, or maybe it's always important.
Len, I see there was one question I don't think we addressed here. It said, on a separate but related topic, have there been any studies comparing the efficacy of oral versus topical steroids, and can effectiveness, which would include reduced scaling, increase when could you use oral and topical together?
We use oral and topical together all the time, and the reason for that is that you can achieve in a local area topically some benefits in addition to what you might be getting systemically from the oral drug. And so if you're somebody who has a lot of scaling on your forehead and you're on an oral retinoid and it helps most of your body, but you still have scales on your forehead that you don't like, we will often recommend you use a little bit of topical retinoid to get rid of those scales. We've had patients who are on oral retinoids who have bad ectropion. And if they put a topical retinoid on their lower lid, their ectropion gets better. So we do it all the time. The question is that going to change the risk? And I'm not sure. Just remember that the barrier to any topical medicine is inadequate in most people who have ichthyosis. And so anything you put on your skin will get absorbed. Will it get absorbed to the extent that an oral dose would? Well, if you put, and I think we have one person on the call who may want to comment about that. I don't know whether to do, Alan. But if you put a topical retinoid on your entire body, the question is how much of that gets absorbed to have an effect somewhere other than the skin. Do you have some information for us?
Yeah, absolutely. We actually just did a study where we gave, granted, healthy adults, 16 healthy adults, a single dose of 80 milligrams of oral isotretinoin. And we compared that to 16 children and adults who applied topical isotretinoin to 75 to 90% of their body. And what we found was the adults who took the oral had approximately, I guess it was 250 or 400 times more isotretinoin in their system than the ones who covered themselves with the topical isotretinoin. So very little of it got absorbed. And so when I say that, I'm talking about, for example, when you look at the area under the curve, which is how much total absorption was there in our study. For the oral, it was 16,000. For the topical, it was 400.
And
we're talking about
what kind of doses do these people have?
The patients who got the topical had 75 to 90% either X-linked or lamellar.
Okay. So the barrier in X-linked isn't as severely disrupted as in lamellar, but in the lamellar cases, they don't have a very good barrier. So that's very interesting.
Yeah, they don't absorb anything. I mean, the maximum isotretinoin level we achieved was 15, I believe. And that's compared to, with the oral, somewhere around 1,000.
Okay, great.
So it's just not getting absorbed. It's all sort of staying in their skin.
Was that one dose or was that a continuous regimen?
That was twice a day, every day for 14 days.
Okay.
Versus a single dose of oral isotretinoin.
Okay.
So these patients were applying, relatively small amounts of a topical isotretinoin, but they were getting clearance of their skin because, again, most of the isotretinoin was staying in their skin. And there is evidence, I'm sure. Yeah, I don't want to steal, Dr. Milstone's thunder, but there is clear evidence that when you take a drug, take isotretinoin or any retinoid orally, as compared to when you apply it to the skin, a lot more stays in the skin than gets delivered to the skin when you take it orally, and then it gets in your bloodstream and then goes to the skin. So if you look at the skin concentrations, for example, of isotretinoin, they're going to be much, much higher with the topical. And it's not our topical. It's really, this is a study from the early 1980s. It was about 10 times higher. So you get the same effect, if not better, with the topical, but you don't absorb it into your bloodstream.
Yeah, so this is the principle of topical steroids too. We've known this for a long time. What Alan is telling us isn't surprising, but it's very nice to have that information. We use topical topical steroids in dermatology all the time because it's much less toxic and risky than giving somebody prednisone or dexamethasone by mouth.
Those data, Dr. Milstone, we presented at the Society for Pediatric Dermatology, and we're going to hopefully present some more data at the Pediatric Dermatology Research Association next month. So the data are in the public domain if anybody wants to look them up.
Great.
Just saw a couple other questions or thoughts anyway. Well, Alan covered the Timber trial. That was one. Topical retinoids have been available for many years. Hopefully Timber's better. I wonder if they are reproducing something that already exists and is available. Seems to be more symptomatic relief versus a root cause drug.
Well, let me just address that for a minute. I mean, unfortunately, retinoids do not address the root cause of ichthyosis, of any kind of ichthyosis. And this is where we are in medicine right now. We have a lot of old-time remedies that work, but they work on either a symptom or they work on something that appears to be a problem, but it's not really working on the cause or fixing the cause. And, in the talk that I gave at the last family conference, there's a lot of enthusiasm right now about developing medicines that actually address the cause of problems as opposed to just the consequences of the problem. But retinoids are really, this is not to minimize their importance and their effectiveness in people with ichthyosis, but they're not addressing the cause of the problem.
Hello?
Oh, go ahead.
Hello?
Yes.
Hello.
Okay, sorry, I didn't know if I was on. A question regarding DISH. Are there necessarily inflammation markers in the blood if you have DISH? The neurosurgeon, when they were initially trying to diagnose me, tested for inflammation markers in the blood, and they said I didn't have any, ergo I didn't have DISH or ankylosing spondylitis. But I've read since that they don't always show.
So I have not read anything or seen anything about markers specific for DISH, but I will tell you that there is a huge industry of investigators out there looking for blood markers for almost anything you can think of. And the reason for that is that we have much more sophisticated testing now, both for proteins and for RNA in the blood, that might allow us to see some of these markers. And so I have not heard of any for DISH. but that doesn't mean that there aren't people looking for them.
Okay, well, it was sort of based on that, the fact that there weren't any inflammation markers, that they said they did not think it was either of those things. I've been on retinoids for just over 40 years, 50 milligrams starting in 1982, and then about 20 years ago, I had to go to 75 milligrams, and I'm quite severely impacted. Yeah, I believe it's dish. I've yet to have a professional diagnose that, including I've been to a rheumatologist twice, and they don't. They said it's mechanical back pain, was their diagnosis for it. Coupled with that is flash pains, nerve flash pains that has developed as well, accompanying it. So I get pretty significant pain.
When you guys are talking about dosages, are you talking that is per day, or how often are your dosage?
So I want to say the dosage that we're usually talking about is a daily dose.
Okay.
But I need to remind everybody that drugs such as isotretinoin and tretinoin and are generally, when they're given orally, they're dosed on the basis of your weight. So, the bigger you are, the more you need to achieve the same effect.
Can I just clarify something again about DISH? This is calcification on the ligaments, which are basically attached to your bones. So it feels kind of like a skeletal issue, but it's actually really the ligaments that are the problem, kind of.
Right. In
okay.
general,
so it's nothing on your actual bone.
No.
Okay.
And that's why stiffness is the thing that, the ligaments allow you to move without moving too far. But you get stiff if those ligaments get calcified. So, Philip, I think that it's important for somebody like you to be talking to your dermatologist and your rheumatologist, because we need to be educated on symptoms. We talk about DISH in the general population, but the DISH that's caused by taking a retinoid could be different. I mean, it may have the same appearance on an X-ray, but it could be different. And I'm not open to closing the door on what we know on this problem for people who have ichthyosis and are using retinoids. I mean, I think that there's still a lot that could be done. And I think some kind of a study would be valuable, but we haven't been able to get enough people and enough money to actually do a prospective study to seriously look at this problem in ichthyosis patients who are taking retinoids.
Leading up to this call, I mean, I did hear from 2 other members that they would consider themselves severe. Just FYI, so it's not just you, Philip. And that's why Len was so generous to offer to do this session. And maybe there would be another follow-up after this, Len. I know you offered.
It's not a subject that really anybody's familiar with, I don't think. I doubt that most dermatologists I've dealt with have never seen ichthyosis. And even the rheumatologists have never really encountered somebody with that condition that has these sort of arthritic, what could be termed arthritic conditions. So it's a little bit difficult to sort of get any clinical. I still have yet to have a clinical diagnosis of what's going on.
In dealing with DISH, say in your neck, have you found that for the stiffness, have you found acupuncture, massage, chiropractic? Has anybody found what would work better? I have a hard time turning this way, like when I'm driving at some periods of time, my neck gets quite stiff. So just asking, what has anybody found anything that seems to help any of that?
The thing that's helped me the most is, sorry, ma'am. The thing that's helped me the most is massage therapy. Okay. Second is physiotherapy. And beyond that, nothing else has helped. Chiropractor hasn't helped. Any of the other things. I also have great stiffness in my neck. I've had to quit driving because I can't turn fast enough. I have to turn my whole trunk to look for the car, and then I got to turn the other way to look the other way, and it's so slow by that time I have to look back the first way. So I finally just said this is very dangerous to be driving anymore. I have a great deal of trouble swallowing, often choke. So the swallowing reflex is impacted. My head is severely bent over. I basically walk around bent over and looking straight down at the ground. So the neck is really hyperextended down. And it's very, very stiff.
So I would like to just emphasize that Philip has done all the things that I put on the slide. He's been to his rheumatologist to have ankylosing spondylitis eliminated as a cause of his problem. He's doing the kinds of physical therapy that probably help all of us. I mean, I don't know whether I have dish, but I can tell you I have a hard time turning my head as well. I know nobody my age who doesn't. But that doesn't mean that a little bit of physical therapy wouldn't help. So you've been doing all of the good things. Thank you.
I do both once a week, so it's pricey, but it's about the only thing that helps. The other thing that the neurologist put me on is an anti-inflammatory, celecoxib on the maximum dose, and that has made a dramatic difference or improvement from what I was. I went from very bad to just bad.
What was that called again, sir?
It's an NSAID, celecoxib, NSAID. And the drug is celecoxib, CELECOXIB.
Thank you.
Okay, has everybody gotten their chance to ask a question or make a comment?
I think we got everything in the chat. So
okay, great.
Anyone else has another question?
And how is this?
Thank you very much, Lynn.
Being this was recorded, how is this emailed then, or?
Well, what I normally do is I will share the recording tomorrow with all of you, but it will live on our YouTube channel for anyone that needs to, who missed it tonight, would like to see it.
And what is that?
If you go on our website, there's the social media channels at the bottom.
Okay.
Or else just go into YouTube and type in Foundation for Ichthyosis.
Yeah.
It should be there by tomorrow. Anybody else?
Okay, now we can all go and root for the Phillies.
Thank you.
Thank you.
All right. Thanks so much, everybody. Thanks, Len.
All right.
Thank you.
Len, have a good night.
All right.
Bye-bye.